Hello everyone. I'll be talking to us all today about school eye health in Nigeria, the situation now and what the future holds. My name is Adio. I don't have any financial disclosures. The first thing is that children have rights. The Convention for the Rights of the Child was adopted by the United Nations in 1989. And there they recognize that for the first time, children have rights of their own and they are not passive objects of care and of charity. And the rights they have is to health care, nutrition, to clean water, to a safe environment, for quality education, and the right to guidance from a caring adult. And of course, this will ensure early identification and early presentation for uptake of eye care services, and also ensure follow-up, including the lifelong approach to care. Now, schools are the major institutions in the society established for the purpose of transferring knowledge and culture to the young. Childhood blindness and visual impairment produces many years of living with blindness and vision impairment, so we need to address this promptly and properly. There has been found a very strong link between children's health, including their visual health, and the quality of their learning and achievement at school. This in turn affects their future, the quality of their life, and the economic productivity that they have. School eye health programs provide a unique opportunity to deliver comprehensive eye health services to school-going children. So that brings us to what exactly is school eye health. Now, this is a comprehensive health service that has been set up exclusively for school kids to enable them work and learn in a healthy, conducive environment, as well as to receive eye care. But it requires teamwork. It's not a one-man thing. It seeks to maintain and improve not only the health of the school children, but also the staff through instructions, health services, healthful school living, as well as through school community cooperation. We'll just go through the benefits. There's so many. One thing is the correction of refractive error and provision of affordable, durable spectacles that look good and are comfortable. Identification and referral of children with other causes of visual impairment. Identification, referral, and treatment of common eye complaints in children, and also of teachers with visual impairments. And also, if these teachers require reading spectacles, they should be provided. So the essential aim of school eye health is to prevent blindness. Now, the services that need to be rendered include the promotive ones, preventive, curative, and rehabilitative ones. And one of the objectives is to ensure good eye health of school children while the children take advantage of the education provided. Another one is to prevent eye diseases or injuries. Furthermore, we need to provide information on the importance of seeking care early in order to prevent blindness, and also detect and treat eye problems by health personnel that are relevant. Also is to attract participation of school teachers and help them to understand the need to acquire skills to detect eye diseases early. Also, to provide knowledge on first aid care in accidents or injuries. The other couple of things that we need to know also is to promote positive eye health by making the pupil conscious of the importance of their sight throughout life, and to discourage unnecessary absenteeism and truancy at school by attending eye hospital. We need to have child-to-child method of screening by their full participation. These children need to understand visual acuity in addition to the teachers, so they can help other children, their families, and the communities at large. In addition, it promotes healthy school living through encouraging safety and sanitation, proper food services, and proper mental and emotional health. And of course, if there are any problems, we can find all this out by carrying out research. The World Health Organization reports that 43% of all visual impairment is due to uncorrected refractive errors, and this amounts to about 12 million children. A recent study demonstrates that programs for the detection and treatment of uncorrected refractive error among children is definitely cost effective, so it needs to be invested in. Now, what about the situation in Nigeria? We have quite a large number of children also. It's a highly youthful population, and most of the causes of blindness among them is uncorrected refractive error, and this is the commonest cause of visual impairment. Now, why is this? There are rising poverty rates, there's poor education and underfunded healthcare systems, and the majority of eye care workers, especially ophthalmologists and optometrists, are concentrated in the urban areas. And in the absence of accessible orthodox eye care, patients access other sources. They could go to traditional healers, go to cultures, and this will exacerbate the visual loss through harmful practices or even delay the proper treatment. Like I said earlier, there's inequity in access and higher costs for patients and providers. And of course, eye conditions like conjunctivitis and presbyopia, which can be treated at primary level, now are principally delivered at just secondary and tertiary level. Now, looking at the under 5 mortality rate, this is a proxy indicator for the prevalence of childhood blindness, and this has declined over the last 40 years to about half of that, with the figures that were given in 2018. Also, happily, there's a decline in major preventable causes, such as corneal blindness and vitamin A deficiency disease. But there has been a steady increase in the burden of non-communicable diseases, such as inherited congenital cataracts, retinopathy of prematurity, retinoblastoma, and cerebral palsy. And all these have a sight-related burden. So we need to have an efficient school health program. And this is a very cost-effective investment if a nation can make the sacrifices that is required. Now, this has led to several global initiatives to enhance school health in the context of health, education, national development, the rights of children and persons with disabilities. And globally, the school health initiatives are the one that has been set up by WHO, UNICEF, and UNESCO. Now, eye health is an essential part of a school health program. So it's not just the eye, there are other aspects also. But the strategies to carry out all this need to be comprehensive, and you can't just hold on and be looking at just refractive errors alone. You need to look at the child in totality also. So this is just one of the strategies of school health programs. Now, the goals, using the Sustainable Development Goals. The first one is no poverty. Restoring someone's sight is the single most cost-effective health intervention to reduce poverty. And we know that approximately 90% of those who are visually impaired are living in developing countries. So that is one goal that needs to be looked at. The third goal is good health and well-being. By 2050, it has been documented that half of the world's population will be myopic. One of the reasons why we're also talking about myopia in the second talk that I'll be giving later on. The fourth goal is quality education. If you struggle to see, you struggle to learn. 80% of what young children learn is processed through their sight. The fifth goal, gender inequality, equality. Women and girls are less likely to access vision services in many countries. If a girl has her vision corrected, she has a better chance of achieving more. And for each year she stays in school, her income will rise by 10 to 20%. So an educated girl would grow up to gain her rightful place in society and be a force for change, raising the status of girls and women. Number 8, good jobs and economic growth. The global economy loses a lot of money in productivity each year because of uncorrected vision impairment. And some have described it that it's more than the total GDP of 60 countries combined. Goal number 10, reduce inequalities. The burden of blindness lies with developing countries. And the prevalence of blindness in children is almost 10 times greater than that which has been seen and documented in developed countries. And so this is important for us to look at in our country, Nigeria. Now the components, an ideal one should be integrated, like I said, into the broader school health program and should encompass the following: screening, referral and treatment, health promotion and education service delivery, and follow-up. Looking at school health, eye health, it should be planned properly. Before you start any work, everyone needs to be clear on what the objectives are and how the team will monitor their progress. Only then will all these programs achieve their maximum impact. We need to decide what is the visual acuity cutoff we want to look at. Is it 612? Is it 69? What age do you want to do the first examination? In India, they use 5 to 6 years, primarily because it is easier to examine this sort of children at this age. What equipment do you want to use? What will you do when you find a need? There is no point in doing all this identifying problems and then you don't have any solution to offer. And then what referral systems are available? So looking at screening, referral, and treatments, there are 3 basic activities. The ones to benefit the school children, and the ones to benefit the teachers, and the ones to benefit the communities. To benefit the school children, the refractive errors need to be treated and detected. Other eye conditions need to be identified. We need to train school nurses and teachers to detect and treat simple conditions. Our health education also on how the children can keep their eyes healthy. So these activities will benefit school children. Then the teachers themselves, if they cannot see well, that will be a very big problem. So glasses also need to be given to these teachers. And also, some teachers may have a history of cataract, glaucoma, or diabetic retinopathy. They need to be seen and then refer to the appropriate quarters to have themselves treated. And then to the community at large, teaching children how to be agents of change is an investment so that they can also extend all this information to their families and their communities. I've listed the equipment that is required there, and including student record sheet and of course referral sheets. The procedures are the usual ones. I'll just stress that you must ensure that the chart is at the student's eye level. Of course, you must use an eye occluder or a piece of card. You shouldn't tell a child to use their hands to cover their eye, so some of them may peep in between their fingers. And of course, to see any particular line of the chart to say that this child can see it, the child must be able to see at least 3 of the 5 E's of the letters. Of course, the chart is recommended to be an ETDRS chart. To limit memorization and to improve reliability, a tumbling E-chart can also be used. And you rotate the charts in between the eyes and in between children so that they don't memorize it. Only one student should be in the room at a time. Keep others outside, because as one child is reading out, another child will just be memorizing and come in, even though he cannot see, and start reading out the same thing. If a child requires refraction, there are certain indications. Children whose visual acuity does not improve to normal must be referred for examination to determine the cause. And there are indications, like I said, if they are uncooperative. For cycloplegic refraction, you have to do a cycloplegic refraction if they are uncooperative. If there is a variable or inconsistent endpoint to refraction, if there is strabismus or a suspected amblyopia, or if they are even difficult to refract because there's a medial opacity or there are irregular corneas. So health education to prevent locally endemic diseases needs to be carried out, especially to promote clean, safe, and healthy school environment. You need to encourage children to take these messages to their home. Either you give them information sheets or pamphlets or send a message to their parents. And they can also act as case detectors. Now, this health education component should be delivered by qualified eye care professionals so that they don't have issues of saying things that are not completely correct. Nurses that have been trained in that area, clinical officers, optometrists, at a level that the children can understand. Now, the purpose of this is to increase their knowledge about the eye, how it works, and what can go wrong, and to tell them how they can keep their own eyes healthy. Normally, this should be an integral component of the school curriculum, but we're getting there gradually. Talking about service delivery, ideally, the Ministry of Health ought to provide financial support for these programs, including the provision of spectacles. If this fails, we need to keep it affordable for parents, the glasses and the tests and everything. Now, the key to a successful program is well-trained and dedicated eye care personnel with clearly defined roles and responsibilities. Now, if you do a test and you find that the child requires low-power spectacles, this should not be provided because they won't wear it, and it's a waste of resources. And therefore, the program will now be open to exploitation through unscrupulous prescribing. The personnel that is required to carry out all these tests are listed there for you to look at when you are looking at this webinar presentation at a later date. But it's important to also teach the teachers. Like I said, it's a team effort. In the first session, ophthalmologists can train the teachers to recognize eye conditions in children. And then in the second session, optometrists can instruct them in vision screening using eye charts. The best is actually to just give a particular line of charts that you want them to look at. And then you also show them the distance that the chart should sit and where they're supposed to write, where they're supposed to record everything that they're recording. This helps us to be able to limit the number of personnel because we don't have probably enough personnel that will go around all the schools to get all this sorted out. Now, the success of any program depends on follow-up. Resources should be allocated to this, and systems should be put in place to follow up everyone who fails vision screening or who has been found to have an eye condition. Follow-up is also required after you refer for refraction, after you have given glasses, or you want to ensure that an eye examination has been carried out at the local hospital. And of course, accurate and efficient record keeping is very important, both by those who are screening and referring and those who are receiving the referral. Monitoring of progress must be smart. The objectives guide the data that needs to be collected. Numbers vary from place to place depending on the information from publications. You may want to look at different publications wherever you are to ensure that you are doing the correct thing. For example, the number of teachers who are trained needs to be monitored, the number of children screened, the number of children given glasses, number of children referred, and definitely after a period of time recommended to be 4 months, you have to check the number of kids who are still wearing the spectacles you gave, how many teachers were given glasses or referred for treatment, and how many remain satisfied at that point. So to improve delivery, there is a need for low and medium income economies to provide universal access to eye care for blinding conditions and for those that cause ocular morbidity. And the World Health Organization has given us an approach for that, a primary healthcare approach. This will help to increase access to eye care. Now, the challenges that we have. Few school eye health programs are going on. Many school eye health initiatives are narrow in focus and don't involve ministries of health or education. They are not integrated into other school health initiatives. And generally, they don't provide annual or biannual vision screening to identify new cases and to follow up those who have been identified. Now, all this combine to lead to poor coordination and ownership and sustainability. And there is also lack of standard approaches to screening, prescribing, referral, and follow-up. In addition, we have difficulties with parental cooperation, and political will has been found to be a huge burden, and poor funding has also been a stumbling block. Other challenges include inadequate monitoring and evaluation, lack of equitably distributed trained personnel, the lack of available and of appropriate and affordable spectacles and lenses for children who need them, and also poor access to specialist treatment, especially those who are in the rural area. So what does the future hold? We need to critically analyze the present situation. We need to identify areas of strength, weaknesses, and opportunities that can be leveraged upon, and the threats that need to be addressed. And of course, we need to adopt a coordinated approach. This is lacking at this time. To establish a need and a degree of need, we need to do a mini survey in your area. You can obtain also information from other local school eye health programs or the Federal Ministry of Health. We need to look at the prevalence of vitamin A deficiency in preschool age children and the prevalence of severe vernal conjunctivitis in children. This has a direct impact in helping us to plan properly. One significant weakness is inadequate funding of child eye health. Funding, very important. We need to understand that this is a very important area. Happily, in 2014, the National Health Bill was signed into law, and it became the National Health Act. And some money has been earmarked for the Basic Healthcare Provision Fund. And the goal of this fund is to substantially increase revenue and improve the primary health care that has been prescribed by WHO and as contained in the country in the National Health Act. But where is the child eye health in this budget? The ideal thing is for it to be included in this budget and also in the state eye health and general health plan. Refractive errors have been targeted for intervention through a school eye health program, but it's not in full manifestation at the moment. Only in pockets of areas and some NGOs that have been carrying out some activity in this area. Insurance schemes or formal private-public partnerships also should include treatments for eye conditions of children. And of course, if there is personnel constraints, teachers can be engaged, and this will reduce the burden of payment for services. Now, we shouldn't be tired of advocacy. We need to tirelessly advocate the stakeholders, the Ophthalmological Society of Nigeria, the Nigerian Pediatric Ophthalmology Society of Nigeria, the Nigerian Optometry Association, and all relevant bodies need to keep advocating to all the government parastatals. We need to keep writing academic papers in this area to support the need and to show that there is a problem in this area and publish them in visible journals. We need to continue to do awareness programs, radio programs, TV programs, publish IEC materials, visit the ministers for education, commissioners, social welfare, special ministries, permanent secretaries. The NUJ also needs to be brought on board. FIDA, those are the lawyers, female lawyers need to be brought on board for gender equality. We need to keep doing social media blitz, raise funds as much as possible, conduct workshops to train teachers, talk with the PTAs. All this needs to be done to be able to help this program to get on board properly. We also need to train teachers, like I said, to conduct this screening carefully. They are the ones that are perfectly placed to identify children who are at risk of vision impairment before it impacts on their educational attendance and performance. And once we're able to do that, early detection and treatment, this can be corrected with simple interventions such as a pair of glasses or low-cost surgery, and so on and so forth. We shouldn't forget color vision. We should also have a coordinated plan for special children. Dispense only the kind of lenses that will be used, because only if you give glasses to those who don't need them, it has made those who need them, it has deprived them of that. Then you should have a plan for sustainability. And the take-home messages that I would like to give us today. First of all, school eye health programs provide a unique opportunity to positively influence the health of 700 million children globally and 12 million and plus within the country. The impact of school eye health goes far beyond good vision. It encompasses education, social development, and economic productivity. They have a potential to change the lives of children and their teachers by detecting eye conditions and ensuring access to quality eye care. Health education delivered at schools also has the potential to reduce eye disease and visual impairments in the future. These programs should be undertaken in collaboration with the Ministries of Health and Education. We need to monitor and evaluate so that we can make good use of the resources and bring about positive change. These programs need to be funded in a sustainable way with full involvement of teachers and parents and the community at large. And finally, we as ophthalmologists should be ready to actively lead the team to resuscitate school eye health, as the future of our country depends on this. Thank you very much for listening.